seem to affect and increase their risk to have injury, but specifically limited dorsiflexion seems to be more, that affects it more than anything, and obviously a tight calf will have that. They're also more at risk from that because they're not really able to load and spring off that leg and that foot, that calf and that foot like they should. Just like we see with a lot of our athletes, those that seem to be better at balance and proprioception do better in general, ankle injuries or leg injuries. Extrinsically, things outside of the body, kind of the biggest factor out there that I was surprised I'd never thought of was the type of sport played. Soccer seems to be kind of the most at risk versus the rest of them. It's a little harder to tape and brace somebody going into a cleat than into a basketball shoe. At least they complain about it more. Indoor seems to be worse than outdoor, but interestingly enough, soccer on natural grass versus any kind of artificial turf seems to put people most at risk, especially if they're playing at the defender position. I'm used to the days when AstroTurf caused a lot of injuries, so we're seeing it a little bit differently now. Landing in volleyball seems to be a close second place. A lot of it has to do that they're landing on teammates that are crowding the net. So just a real brief view of anatomy. I know you guys know it, literally like the back of your hand. But the tibia and fibula, or as my patients like to call it, the tibula, just to get both bones all together. Most of the, let me see if I can figure out how to work a pointer on this thing. I don't know that I see one. Anyway, towards the top of the tibia, off the medial tibial plateau, the mid-tibia, right where it says medial surface on this diagram, and then the medial malleolus. Those are the three areas most common for stress injuries. I know I'll see a lot of stress injuries and stress fractures kind of at that distal third in this diagram, right where it points to, right where the landmark is, where it points to say tibia. But it seems in general, whether it's a bone bruise, a fracture, a stress injury, and so forth, it's going to be medial tibial plateau, medial malleolus, or right in the middle, really that medial side. That seems to be because that fibula acts like a buttress. Now, the vast majority of your weight, somewhere in the neighborhood of 80%, give or take 5%, is borne by the tibia. The fibula is really there more for a strut. But it's the medial aspect that seems to take most of the brunt of the force and the blow. Just for your information and your edification, when we're going, it's not whatever we weigh in pounds per step. What it actually is if you're walking, times your body weight in pounds across the knee to the ankle, we know it's similar, and the fibula for that matter. Jogging on a flat surface or going up stairs or an incline is 6 times your body weight, and going down is the worst, and that's what we'll typically hear, especially from older patients. Going down is 9 times your body weight, so it's 900 pounds for every 100 pounds you weigh per square inch. And when I have a patient that weighs 400 and they want to know why they can't get rid of their knee pain, we really, without being insulting, review weight and how that affects it. And that affects, like I said, the fibula as well. In the middle, you have that nice thick strut known as the interosseous membrane. A lot of us will call it the syndesmosis, even though that really refers to lower close to the ankle. Thick anterior and posterior ligament on top where the fibula meets the tibia at the knee. Not a very common area for injury. In fact, those ligaments, you don't really sprain very often. You're more likely to have a non-displaced fracture of your fibula. Down low, that's where we get our high ankle sprains as they start affecting the syndesmosis. And so obviously you can see how injury across this area can really affect. I'm sure a lot of you guys have done a squeeze test before where it's positive, although when they come in their x-rays are negative. That's because when they get enough force to either break their fibula or their medial malleolus or to cause a high ankle membrane pretty high. Of note, and I don't know how much you've ever paid attention to it because we're going to go into ankle sprains on this, If you look at how the medial malleolus comes down off the lower tibia versus the lateral malleolus, you see how there is much more gap medially for your foot to flex inward or invert, and that's part of what sets up that lateral ankle sprains is the most common. Really, when we get down into the ankle itself, besides the tibia and fibula, I almost called it the tibula. The next bone to worry about as we get into the foot is the talus, which is a part of the foot into the ankle. See a high ankle sprain, a bone bruise. This structure, in addition to maybe the lateral malleolus, medial malleolus, maybe the navicular right below that red area in the midfoot, this area seems to be the one that they most bone bruise. Tenderness along this can be a bone bruise, can be a fracture. If it's inside of the fibula and tibia, it can be due to bone bruising, it can be due to a cartilage injury. And most of the guys we're treating don't need an injury to have cartilage problems in the ankle. Well, they're very common in general. They can have an OCD that can be with or without injury that usually needs to get referred right away, because that's something that I'll even get somebody like Dr. Allen, my partner, or refer out to one of the foot and ankle doctors to look at, because that is something that we can really cartilage in the ankle if we need to. Remember, the ankle has no, the articular cartilage is all it is. Laterally, just to show you how the structures relate, obviously this is most of the ankle injuries we're treating. Remember on the ATF, or the anterior talofibular ligament, we can all get fooled because we may have a bone bruise to the talus, which underlies a ankle joint itself, where they have a bone bruise inside the ankle joint, they have an OCD, and that underlies it right there. This doesn't show the anterior ligament of the syndesmosis called the AITF. ITF lies right above it and comes into play, inserts real close to where this anatomy model shows lateral malleolus and has that button for it. That's where the AITF inserts into. And then you can have things such as sinus tarsi. You can have a spring ligament injury, which is just below it. So we can all get fooled from it. Luckily, the treatment is roughly the same. You'll see us sometimes use a boot a little bit more aggressively now than we did 10 years ago, using it as a glorified brace, just to give that area some rest, especially if they have very severe tenderness. Mostly because we know that the rest will help them, especially when they're working with you guys on the side and rehabbing their ankles anyway, getting their motion, their strength back, getting on a bike and progressing. Medially, even though it's really just the thick deltoid ligament, this is more concerning for us from a medical management standpoint. Once you injure that deltoid, a true injury usually means a real high velocity injury. You'll frequently see it injured in a high ankle sprain. That's why with a high ankle sprain, which is an eversion injury, we're really concerned about this area. We will get fooled because, again, if you look, the talus underlies it, so sometimes you'll have bone bruising to the talus. But you'll see a lot of us put people on crutches initially, or put people in a boot appropriately for a high ankle sprain and manage them for the first week or two in that boot or on those crutches, trying to get this area calmed down. There's studies that were done 20 years ago that showed that actually could shave up to 4 weeks off the rehab time on the back end if you do that. So any medial tenderness you definitely want to protect and maybe get in a little sooner. So when should is an appropriate time to refer injuries? And I'll go over injuries based on the injury symptoms. I think any pain with weight bearing is probably deserving of an x-ray, whether it's with the patient, physician, sports medicine doctor, going to an ER, going to an urgent care. And I'm of the school of thought, orthopedics. It is not a lot of radiation. If you want a lot of radiation, we'll CAT scan